I'm David.
And I'm Matthew.
And this is the Handoff Report. It's a show, it's a podcast about the cool stuff that human individuals learn in nursing school.
Could you be like a dog and do nursing school?
Oh, well, if you can be a dog and get the Medal of Honor for saving a cop's life, you can probably be a dog and go to nursing school. Today we're going to talk about the very first thing you learn in nursing school, called the nursing process.
You made a little gesture there with your arms, like the rainbow thing.
Yeah, from SpongeBob. Imagination. No, yeah, the nursing process. In nursing school, we are fundamentally re-taught how to think critically over the course of 2 years. The first thing they teach us is called the nursing process. And here's the cool thing about the nursing process. It's like a way better version of the scientific method.
It's a bold claim.
I'm a bold person.
No arguments.
I'm wearing my Mark Anthony shirt today. I'm a bold person.
Then you're...
No, stop it. So nursing is a science, okay? So it's why it's a bachelor's of science in nursing. The nursing process is like the scientific method because it's a way of asking a question and then solving and like answering that question. But for the nursing process, it's asking a question and then doing something about it, which I really like.
In like a structured way.
No, yeah. If you don't even care to be a nurse, listen to this because it's such a cool way to go about problem solving. It's a 5-step process that follows the abbreviation ADPIE for assessment,
diagnosis,
planning,
implementation,
and evaluation. Implementation or intervention. Now I don't remember, but those two mean the same thing.
I've heard it both ways.
Oh, yeah. Let's just go ahead and go through the 5 steps of the nursing process. Are you ready?
Oh, yes.
Okay. So, let's walk through a scenario. It's a dark and stormy night. But that's irrelevant.
That's pretty irrelevant.
A burn patient comes to the trauma unit. Maybe they have 2nd or 3rd degree burns, which means it's not just reddened skin. We're talking about damaged layers of skin. Maybe some exposed tissue on the inside. When this patient comes in, the nurse needs to assess the patient and gather a ton of data. This data is used to formulate a nursing diagnosis, which we'll talk about in the next step. But when you're assessing, you're making a ton of split-second observations. Some of the assessment is super technical, and maybe it's a numeric value like their blood pressure. Maybe other observations are a little just what you see, like stuff with your senses. Like what does the breathing sound like? What color is the burnt tissue?
And that's what makes like health assessment so important, and knowing what normal is. Because without knowing normal, you could look at a burn patient, and I know this sounds kind of stupid to say, but you wouldn't know anything's wrong with them unless you knew what a normal person is supposed to do, function, act like.
There's sometimes just these alarming subtleties. But that's the first step. Gather info. Use like your eyes, your ears, your nose even. Like you have to do all this assessing, and you have to be very thorough. And you have to have a routine for how you assess in nursing school. They teach you how to do it kind of in a systematic way so that you're never skipping something important. What does the burnt tissue look like? Does the patient respond to questions like, tell me your name, or what day is it, right? Does the patient look asleep and unresponsive, or is the person pretty much with it? Or as we say in the business, alert and oriented?
A&O.
So let's go back to our scenario. The patient comes in and has these burns, say on 40% of their body. Like what kind of stuff would you assess for this patient?
Well, I would use an ABC method, airway, breathing, circulation. So I would check where the burns are, if they're over an area where there could potentially be respiratory issues. You need to take care of that first. That's like a lot more emergent than other things. You want to look at breathing. So how are they breathing with like smoke inhalation, maybe carbon monoxide?
For those of you prepping for the NCLEX, a very, very attractive answer is like whether there's something black in their mouths because they've inhaled smoke, or whether their breath smells like smoke. There's some
smoke tips
inhalation.
and tricks.
Yeah, smoke inhalation is a very, very important thing if someone comes in with burns. Like, did they come from a fire or something?
You're looking at vital signs to see where that's at. It's like circulatory volume from dehydration. You're looking at to make sure like they're being perfused, which means the blood's getting everywhere. So there's a lot of different ways you can take it. But I think the important thing is like bringing all that and being able to take it all together for what it is, and then figure out, what is this?
Yeah, what am I looking at? Right? And so all that information you gather in the assessment, you kind of, in nursing school, are taught to organize it in a way where you know how to prioritize, right? And so everything you saw and heard and measured about the patient, you have to put that together and be like, okay, what's wrong, right? So that's where the next step comes in. After assessment comes diagnosis. So I didn't know this until nursing school, but nurses make diagnoses all the time. And it's confusing because they don't make medical diagnoses. They make nursing diagnoses. So that's like, there's a distinction between them. Like, so a doctor might say that someone has diabetes or fibromyalgia, or like, what's that one that's on TV all the time?
Mesothelioma?
Yes. if you or a loved one has heard of someone having mesothelioma.
Asbestos.
If you or a loved one has taken medications to treat the side effects of warfarin, you may be entitled to it.
And it's always some guy who looks like Tom Selleck.
It's like, am I supposed to call my doctor or like get a reverse mortgage?
Watch reruns of Magnum PI.
So, doctors might say someone has diabetes, right? But a nurse doesn't diagnose that. That's not the nurse's job, and a nurse would get in trouble for making a diagnosis like that.
Yes.
Matthew says, fact check true. What a nurse can diagnose is things that have to do more with, so hard to describe, but things that have to do more with
like what does that mean for the patient?
Yeah, what does that mean for the patient's well-being and comfort level? So here's an example. Let's take diabetes as an example. A doctor will say someone has diabetes because diabetes makes you want to urinate more. The patient is at risk for like being really low on fluid. They might be at risk for being dehydrated. So a nursing diagnosis would be, quote, fluid volume deficit. You have to use these like pre-prescribed parlance for these diagnoses. And it's standardized so that everyone knows what you're talking about.
You have to buy the book. It's thicker than the Bible. And it's full of all these.
It might even be thicker than that last Harry Potter book. The monstrosity. It's a great book. It's just enormous.
There you go. I was waiting for that.
So you see how a nurse doesn't say, oh, this patient has diabetes. No, what a nurse identifies what a nurse can take care of. A nurse can take care of whether someone's dehydrated or not. But see, you don't say, oh, this patient's dehydrated, right? You say, oh, this person has fluid volume deficit. And it's just super annoying, the parlance.
But you want to make a distinction. There's a difference between how you say it in nursing school and how you say it when you actually get to a hospital.
Oh, yeah. Because
if I said fluid volume deficit when I'm giving like a report or something like that, I might get stabbed.
What an egghead. No.
Are you new here? You would say, oh, they're dehydrated. No. Or according to this lab or this lab. So like there's nuance to that. And part of that's just, you just got to play the system.
But there are nursing diagnoses that you use all the time.
Oh, absolutely.
In the ER, for stroke patients, it's really important to communicate whether someone has altered mental status. And altered mental status has to do with how you're tracking with their level of consciousness, which we talked about earlier. You have to know these diagnoses. You have to get familiar with them. They're a pain to learn. but they're very important as a scientist, right? To know what you're talking about and know how to communicate about it. These diagnoses help you organize what the problem is so that you can decide what to do about it. Because once you know what's wrong, figuring out what to do becomes very, very easy.
It takes all your observations and thoughts and organizes them into these diagnoses that you can then use to create a plan. So it's kind of a way of simplifying like the sensory overload that you have.
Yeah. So let's say our burn patient in our scenario is lethargic. He's in pain. Maybe you'd say on a scale of 1 to 10, he's at a level 8. And we can, maybe his, urine output is only 20 milliliters an hour. The diagnosis comes from a few things we know about burns. So maybe we would say this person has fluid volume deficit. And we know that because when someone's burnt, as much as, our example patient, your cells are filled with water mostly. And when you burn all that stuff away instantly, you've suddenly lost a lot of water in a short amount of time. All the stuff that's in the cell gets dumped into your bloodstream. And so that can cause a lot of problems. When you've suddenly lost a lot of water, it's like you've gotten instantly dehydrated. And then the stuff that's in the cell, mainly the electrolyte potassium, if you just dump a ton of potassium into your bloodstream because of a burn injury, potassium regulates how steady your heart beats. If you mess with those levels, your heart will start dysfunctioning and it could lead to serious injury. So a diagnosis might be fluid volume deficit. And how do we know this? It's confirmed by how the patient's urinating too little. And then all that potassium, or hyperkalemia, as we say, all that potassium, you could say risk for like a cardiac injury or something like that. It can be a diagnosis because you're worried about that potassium messing with how steady the heart pumps. So the biggest issues are with their heart, with their breathing, and with their fluid volume balance. So these diagnoses are helpful because once we have a diagnosis, we know what to do. So, it's kind of intuitive. If someone has fluid volume deficit, what do?
Maybe like more fluid.
Ding, 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 ding. No, yeah. So you add volume. That's just it's just a simple example. If someone has, your diagnosis is low blood sugar, you can see how the diagnosis leads to the plan in a very step-by-step way. Moving on to plan. Plan is basically the step where the nurse needs to set goals for the patient. You can't set ambiguous goals like patient will get better. You have to have specific ways you plan on measuring how they get better.
Yeah.
So in nursing school at first, it's really hard to differentiate planning to implementation because you have to train your brain to think in steps like that. Hey, so before I do anything, I need to decide how am I going to know if the patient's getting better or not?
I always thought planning was, okay, what does this mean for the patient? Implementation, okay, what does this mean for me?
Oh, exactly. That's why it's helpful for you to write your plans with the 2 words patient will. Those should be the first 2 words when you write goals. And then when you write your implementation statements, you say nurse will. So let's see. If the patient's potassium is too high, like a normal range is 3.5 to 5, milliliter equivalents or whatever per deciliter.
That checks out.
3.5 to 5.
So equivalent, whatever, deciliter.
Nobody
I don't
cares.
know. They're not going to test that.
Nah. Just know 3.5 to 5. Maybe the patient's potassium, because of their burns, is at 6.5, which is too high. So a goal for the patient might be, patient will have potassium level of 5 by the end of shift. So do you see how I made it specific by saying, they're going to go all the way down to 5.
I don't know if that's attainable, though.
Well,
or realistic, excuse me.
It's an example.
Okay.
And then, it might be if you're aggressive enough.
That'd be pretty aggressive. This isn't important.
Well, it's an emergency to have that high of potassium.
No, it is. But if you take them down, I don't know if you could get them down that fast.
Well, it depends. It's 12 hours.
That's true. I guess you could do it through other means other than just. It's possible.
Maybe some music therapy will help lower
Yeah,
it down.
just get the trombone out.
And some bongos.
Bring the therapy dog in. You can dance around.
Come on, Shiloh. Anyway.
All these are very valid plans you can do.
Absolutely.
Just throw all those in there.
The more the merrier.
Spice of life.
Mm-hmm. So this seamlessly flows into implementation. We have a goal, but now the nurse needs to decide how to get there. So for burn patients, it's pretty straightforward. You can say nurse will give like X amount of liters of fluid, right? Or nurse will administer such and such medication so that the cardiac rhythm stays the same. Or nurse will, you can, the plan for the nurse doesn't have to be doing something. The nurse can just plan to keep monitoring the patient.
Right, that's a totally valid.
It's totally valid. Like nurse will measure potassium every hour. Like nurse will monitor cardiac function. Or nurse will coordinate with wound care nurse for the burn wounds, all that stuff.
They don't all have to be like Formula One answers. You know, you got to have a few Hyundai Elantras in there. Something that'll go 0 to 60 fast. But sometimes you just want a daily driver, you know?
Sometimes
Still works. Gets you there.
Anyway, the last step in the nursing process is evaluation. Evaluation is the step where you look back at your plan or the goal that you set and you ask, did the patient meet this goal? If yes, then great. If no, then state that the goal wasn't met and then describe in objective terms what happened. Maybe it's not the time to start throwing people under the bus.
No way.
Or throwing yourself under the bus and like incriminating yourself if a patient didn't get better as fast as you wanted them to. But if you wanted the potassium to go from 6.5 to 5, and by the end of your shift, you only got it down to like 5.7, then just say patient at 5.7, and then maybe offer or start thinking about what else you could do.
Mm-hmm.
Don't get too bogged down in why it didn't work. You don't have time for that, right? You got to focus on, hey, what are the next steps to keep trying to treat this patient?
Yeah, it's about taking what maybe didn't work as well as you want, figuring out, okay, like what are my next steps from here? What have I not tried? Did I try something and for some other reason it didn't work? And this is why. So it's like it's just a reevaluation of your plan.
Yeah, and it's important to write this stuff down as a nurse because the next nurse can look back and see what works. If someone has pain, level 8, and the nurse gave morphine and it kind of went from 8 to 6, but when they were like on a regular schedule of Tylenol, maybe that really controlled it and got it down to like 3 out of 10. The nurse who comes in a later shift can see that if you've written it down. They can look back and see, hey, what works best for this specific patient is like making sure the Tylenol is on schedule, keeping track of what works and what doesn't work, and there you go. You've got the basics on how to take care of a patient in the best way possible.
Mm-hmm. And it's cool because the more you keep using it, the less it becomes, oh, I need to write this like 12-page care plan involving it, and it's more up in your head. So you'll go about your day, you'll go into rooms, and when you have a problem or something like that, you can work through it in your head of what you're going to do, and then in a report you share it with the next nurse, you know, of what worked for that day, like some stuff they can maybe do better or change. So it becomes less of this rigid structure, and it becomes this really fluid mechanism that can really make your job as a nurse a lot easier.
Yeah.
I think I was on a clinical rotation in med-surg. It was a behavioral case, but the hardest part was the patient was refusing medications or anything like that and actually trying to escape the unit. So I took all this in during report, and I was like, okay, let me go see what's going on. So I walk in and I start assessing, and I figure out that from my assessment, from asking her questions, that like no one had told this person like what was going on, or like what was happening, what the plan was, nothing. So I took all that and okay, I said, so like what's the issue? And it was that she hadn't been educated enough. So that was kind of like my diagnosis for it. So, okay, what's the plan? And I said, well, I can take some time and go in there and take her plan of care that the nurses and the doctors made for her, and I can just walk her through it and try and make her understand like what's happening, what's going on, what's this medication for, what's that medication for. And then, so that was me implementing it. And then for the rest of the shift, she was totally fine. Stayed in her room, took all the medications. So it was something simple like that.
That's a really cool story. Definitely include your patients. That's the power of patient empowerment right there.
That's a primary function.
This person was just panicking because they had no idea what was going on. And no one stopped no one stopped to be like, have we forgotten her? You know?
That's a primary function of nursing. Because you're a coordinator, so it's your job to be there for the patient and explain what's going on.
I like that example because it's not like, oh, I went in and the patient was like hypoglycemic, so I gave them a cracker, right? No, you identified that the patient was deficit.
No, it was deficit. That would be the diagnosis.
Yeah, the patient had knowledge deficit, as evidenced by all the like trying to leave the unit. And that is so cool that whereas maybe some other people would have tried to medically sedate her, you more effectively treated that by identifying that she's just scared.
You go least invasive first. That's my rule.
That is the nursing process. Once you master the nursing process, you're using it all the time to manage care because you have to do the nursing process for everything that's wrong with the patient.
But the fun part is you don't even know you're using it anymore. So it's nice.
It's cool.
It's pretty cool.
We hoped you found it as cool as we thought. Well, let me try that again. Well, we hope you find it as cool as we think.
There's no need to yell.
Okay. You know what? Anyway, no, we hope you think it's as cool as we think it is. I'm David.
This has been Matthew.
This is the Handoff Report.